Good evening. Welcome again to Senadhipan Education Foundation. Thank you all the participants and the speakers for joining Senadhipan Education Foundation in this evening. For those who are joined, probably this is a repetition. I will go through the short history of Senadhipan Education Foundation. It was launched in January 2012 by releasing a set of educational DVDs by none other than Dr. Sion Han Kim at Taj Hotel, Trivandrum. Then he visited our telemedicine hall the next day, and we were not doing much of online activities till July 2020. We were doing only contact classes. And after July, we released the logo. The logo was released by none other than the god of laparoscopy, Dr. C. Palanivelu himself.
And for the inaugural address. Over to you, sir.
Yeah. Thank you, Nisha. And thank you, Baiju, for inviting me to be today's more remarkable event, part of this. And Goose, good friend of mine, and since he started laparoscopy, I'm very happy about it. Dear friends, Parvinder Lal, Professor Parvinder Lal, Vice President of National Board Examination, and John Abraham, ASI, ex-past President, and friend Raman Goyal, President of IAGS, and Baiju. I think great happiness to be here to launch the logo of Senadhipan Education Foundation. It's something that gives me my heart. And I know him many years and committed himself to this teaching. A man having a skill, man has done a lot of work on this field, minimally in surgery. Again and again, he is very keen to share his experience with junior surgeons and his own colleagues, making this subject popular nook and corner of India.
We thank Dr. Palanivelu for releasing the logo and the words of wisdom. It's an online platform. We perform live surgeries. We are streaming in YouTube. Day first today we streamed live Whipples. We conduct live lectures with eminent faculties like Dr. Senadhipan. We conduct certificate courses in the name of Senadhipan Education Foundation. We have got global acceptance. Actually, last meeting, 9 participants participated in the meeting, and the participants were from Nepal, Indonesia, United States, Egypt, United Kingdom. You name any country, it was there. Now, today we have two eminent people to talk on laparoscopic management of chronic pancreatitis road less traveled. Dr. Sanadevan needs no introduction at all to this audience. He is the head of the Department of SPB surgery, minimal access surgery, and liver transplantation, GEM Hospital, and moderator is Dr. Manash Ranjan Sahu, who is the professor and HOD of All Indian Institute of Medical Science of Bhubaneswar, Odisha, India. Dr. Senadhipan, you all know, is a family person, and he is none other than the son-in-law of Dr. C. Palanivelu. Initially, watching from a distance, we thought that Senadhipan is too lucky to have a father-in-law like Dr. Palanivelu, but watching closely with him, we came to know that Dr. Palanuru is lucky to have a son-in-law like Senadhipan. And I think he has got 6 packs. We will see. Let us ask him. He has got a lot of publications, almost 108 research papers with 2,138 citations in many international publications in indexed journals. He has got many international teaching assignments. This is the one which is the most important in our scenario. Laparoscopic longitudinal pancreatic jejunostomy and modified phrase operation for chronic ulcers. That's the reason why Dr. Senadhipan is here. You all know Dr. Manash Ranjan Sahu, the professor and head of the Department of Surgery in All India Institute of Medical Science, Bhubaneswar. It was very difficult to take his profile from because it took a lot of time for me to write. So I cut a copy of the screenshot of this thing. I'm pasting. He is a executive member of almost all the organization known. And he has got a publication in lateral pancreatic jejunostomy. That is the reason why Dr. Manish Ranjan Sahu is here. So we have some instructions to the participants. Please mute your mic on entry. If your device is named as Apple, Galaxy, or Lenovo like that, you please rename it as your name. Participants logging from outside India are requested to reveal their identity in the chat box publicly. Raise your hand if you want to intervene in between the talk. Everybody will be given a chance to unmute and talk if they want to talk. If you are in a portable device, please mute your audio and video. And when Dr. Senadhipan is presenting, it is preferable to mute your video also, to close your video also, because the video clarity from Dr. Senadhipan will be good if you mute the video also. So please mute or hide your video if you are not in a casual dress, please. And we are having next week, we are having none other than Dr. Leroy with us for TANS anal TME. And we have yet another guest, Professor David Keown, who is the Director of Laparoscopic Liver Surgery, Cleveland Clinic, Ohio, USA, talking about tips and tricks of laparoscopic liver surgery on 18th October 2020. Now over to Manash Ranjan Sahu.
Okay, thank you, Dr. Baiju, for those wonderful words. And thank you for this excellent academic journey that you have been making over the last few weeks, particularly in this pandemic time when surgeons are relatively lacking and they're doing less of elective surgery. So it's a good time to, in fact, exchange and get ourselves enlightened with different techniques and procedures so that when pandemic goes down, probably this will all help to a long way. So I think without wasting much of time, in fact, Senthil has already been introduced by Dr. Baiju. Dr. Senthil is a wonderful speaker. He is an excellent surgeon, and probably each one of us will be getting some insight from his presentation. So could Dr. Senthil start your presentation, please?
Thank you, Dr. Manas. At the outset, I would like to thank Sanadhipan Education Foundation and the chief architect of the foundation, Dr. Baiju, a surgeon par excellence, for inviting me to share some of the experiences which we had in the field of laparoscopic management of chronic pancreatitis. When you asked for the topic, in the last 5 months, every other topic has been covered, recovered, and also relooked. So sort of, I was just thinking what else we have not covered And immediately, the first thing that came to my mind was chronic pancreatitis, like by laparoscopic management. And that's also aptly titled "A Road Less Traveled." During the course of my talk, I also probably also will agree why it is a road less traveled, and probably by understanding the nuances of laparoscopic surgery, we can all contribute. Probably we can travel a lot in that particular road which is less traveled.
And before you start, Senthil, I just want to highlight about the road less traveled. I still remember 10 years back when we started laparoscopic surgery for chronic pancreatitis, a lot of criticisms. Till now, surgeons do not believe that laparoscopy should at all be done for chronic pancreatitis. It should only be done by open surgery. And maybe after your talk, things will be enlightening and people will be trying to accept it. Please.
Definitely. And what is even more interesting and very dedicated, I mean, that shows the dedicated nature of Dr. Baiju is he has aptly
named it.
I mean, made the moderator as well as the speaker. I was pleasantly surprised that he did a lot of research.
Yeah, I was also surprised that he has even taken down the papers and found it and displayed that this is the reason why I have chosen the speaker and the moderator.
Exactly.
In fact,
that is just not a random selection.
Yeah.
It's just, I think we are going in the right direction in the sense we have to identify the original authors, the original contributors, so that apt people, I think you are more than justified in giving a, comment on my talk. Of course, you published in this particular.
In fact, Dr. Baiju looks simple from outside, but he has got roving eyes to look into all the things that we are all doing. So, thank you, Baiju, for getting into it. Thank you also. Yeah.
And on a personal note, thank you, Dr. Baiju, for putting some of, I rightly said, family man, and also, giving a cue to Dr. Pallivelu about, it may not be true, but nevertheless, I like your way of introduction. Right. Can I share the screen?
Sure, please.
Yeah. So my topic today, as I told, is laparoscopic management of chronic pancreatitis. Definitely, it's a road less traveled. Even if you take laparoscopic management of all pancreatic disorders, including Whipple's, distal pancreas, or management of acute pancreatitis, I would say this one particular subset of pancreatic disease is definitely a road which is less traveled. And in a short while, you will be knowing why it is so. I bring greetings from Gem Hospital, Chennai, with which I am attached, and then being here for a couple of years. I moved since I moved from Coimbatore. And there is again a connect between this lecture and Kerala. Lot of publications, especially with regards to the tropical pancreatitis, came from Kerala, because in the state of Kerala, we see a lot of chronic pancreatitis, especially chronic obstructive calculus pancreatitis. Even way back in 1980s, a lot of literatures, including few seminal publications from Dr. H. Ramesh sir. So I think I'm addressing an audience which include a lot of pioneers in the pancreatic surgeries, so that I'm glad, and probably I welcome all the comments from those doyens of pancreatic, the so-called pancreatic surgeons. And the other thing is, we deal with a chronic pancreatitis, which is slightly or more different from what we see in the Western world. Western world is predominantly mass-forming chronic pancreatitis, probably because of alcoholic nature. But we also see alcoholic pancreatitis here as well. But more commonly, what we see is tropical calculus obstructive pancreatitis, where the stone load is high. So we are dealing with our native disease. And for that native disease, I think we should have our own treatment protocol and guidelines. The course of the disease, the chronic pancreatitis, is a long course, starting from acute pancreatitis, gradually moving on to chronic stage, and finally end stage burnout disease. What I'm here to convince all of you that we should attack surgically in the stage B, where there is when the complications set in. For early stage, we have a lot of other treatment options, but when the patient is presenting to us with a pain, with or without complications, that's the time where we have to really look at the morphology, the duration of pain, the other associated complications, and then we decide on the apt treatment for that. This is a very favorite picture of mine. You see, Dr. Baiju is from Trivandrum, but of course, near Trivandrum, we have a beautiful town called Kottayam. I've taken this particular picture. You see, there are very many roads to go to a destination. Our destination is pain relief. Pain relief in chronic pancreatitis is the important destination or important aim of treatment. And for that, we have very many ways of approaching it. It can be surgical, and in surgery, it can be open or laparoscopic surgery, or it can be an endotherapy, which is again coming up in a big way. We cannot just brush it aside that no, it is not working. It definitely, there are literature evidence that they do a lot of modifications in the treatment, including ESWL, including endotherapy, using lasers to just pulverize the stones and then put a stent and then treat them, or even stricture dilatation with all the endoscopic gadgets. Previously, we had a slightly, I would say, a negative feeling about the endotherapy, but the evidences that is coming up in the latest, I think in the last 5 years, have shown that it is also a treatment option. And especially if you consider short-term pain relief, I can say it's on par with surgical approaches. Maybe we have to see whether long-term pain relief is as good as in surgery. And we should not forget the fact that pancreatic enzyme replacement therapy is the cornerstone or pillar stone for majority of the patients. And we restrict the surgery to some patients, a few percentage of patients where there is a morphological abnormality, where it could not be completely relieved by the enzyme replacement. So here we need to have a holistic approach to tackle this chronic pancreatitis, especially the pain. And we need to have an unbiased approach. That is what is very important. It can be, if it can be settled by PRT, please don't go for surgery. If it can be controlled by endotherapy. If you have a good endotherapist, probably we can always ask him to have a try. So like in malignancy, where radiotherapist, chemotherapy, medical oncologist, as well as surgeons, they consult, they do a tumor board discussion and then arrive at a conclusion. Here also, I believe multidisciplinary team, including the medical gastroenterologist, endotherapist, as well as the surgeon, should contribute and finally take a decision in the interest of the patient. When it comes to the surgical candidate, I would say pain not relieved with full enzyme replacement should be a good candidate for surgery. And then, as I told you, it's a second stage 2, wherein the complications are going to set in or already set in. Those are the people we have to tackle surgically. And the complications, obviously, there is no question about it. Either coexisting malignancy, biliary obstruction, or duodenal obstruction, symptomatic coexisting pseudocyst, or splenic artery aneurysm. These are some of the other complications by which we have to contemplate surgery. And among these, coexisting malignancy is one which is, I think, even in the best or the best experienced hands, sometimes it can be missed. So we need to have a high index of suspicion to make sure that we don't deal with CCP along with the malignancy. And also why I said we have to tackle early is evidences are coming. In fact, Dr. H. Ramesh Center has shown that when you tackle them early by surgical decompression, removing the stone load, probably the chance of malignancy can be brought down. The incidence of malignancy post-surgically intervened pancreas can be reduced to a significant proportion. But at the same time, we have to exercise caution in offering the surgery for those patients who have steatoria or who have diabetes. I have a lot of patients, and probably all of us will have following patients who have steatoria, only steatoria, not much of a pain, and patients who suffer from diabetes, even with or without stone load. If you offer them surgical solutions for those this subset of patients, I think we may not be able to cure them post-operatively or control them, or even sometimes it can, evidences have shown equivocal results with these two subset of patients. So I'm not a very proponent of surgery for diabetes and steatoria. It can be a contributing factor to decide on the surgical aspect along with the pain, but this should not be the sole criteria based on which we do the surgical intervention. And I stress on the early timing of surgery because it offers not only complete but also long-lasting pain relief. And there are evidences which shows that pancreatic insufficiency is reduced by early surgery. Probably we try to preserve some of the islet cell as well as the beta cells, as well as the exocrine cells. Low reintervention rate, by which I mean either for pain or for malignancy, is less when early surgery is contemplated and done for chronic pancreatitis. But please make sure the early surgery, by which I mean those patients who require surgery for chronic pancreatitis, not otherwise. If any patient can be managed with the enzyme replacement, no pain, completely under control, probably surgery, we can postpone the surgery. Before I go to the laparoscopic management, I wanted to all of you to know some of the surgical options, because history is very interesting with regards to the chronic pancreatitis surgical management. We have a lot of procedures. I'm just enumerating few of the procedures, right, starting from the historical importance to the present scenario. We have starting from the dual procedure on the original pusto. Original pusto is distal pancreas with the lateral pancreas and anastomosing to the stump of the pancreas. So these are the historical importance, and from there, from the original pusto, we have the modified pusto where the duct is opened longitudinally and then a lateral pancreatogegnostomy is added, so that it is one of the mainstay of treatment, especially in Indian setting where we see more of a duct dilatation, more of stone load. The other important workhorse for surgical intervention is the Fry's procedure, where along with the lateral opening of the duct, starting from tail to body to head, we also core out the head portion, so that head is we all know the pacemaker for the pain in chronic pancreatitis. So you decompress the duct, decompress the side branches, decompress the unsnared branch duct, and also the pacemaker is of the pain is also tackled by Fry's procedure. And by far, if you look at the drainage procedure, Fry's has got the best outcome when you exclude the resection procedures. Coming to the resection procedures, we have distal pancreas or the pancreatoduodenectomy, depending on the predominant disease. In the Western world, we see a lot of pancreatoduodenectomies because it's a head predominant disease, head mass, inflammatory mass due to alcoholic pancreatitis. We also should know some of the less resection procedures like the Bager's procedures, wherein we transect the neck in Bager's procedure, whereas in Burns procedure, the same head coring without transecting the neck. So these are some of the Western oriented resections, but I believe in India, we rarely do Beggars or Burns procedure because the pathophysiology, the disease pattern, the spectrum of disease is different what we see. But nevertheless, it's very important to know that we have resection procedures with or without neck transection. We have drainage procedures. And in the Indian context, I can say Fries is a good procedure. And if you don't have much of a head thickening or head inflammatory mass, a lateral pancreatic jejunostomy is a good alternative. This is, I would say, not much of a literature support, but based on the logical conclusion and the roadmap, a drainage procedure is good for a large pancreatic duct with a better outcome. Small pancreatic duct, less than 5 millimeters, you need to add some sort of resection, at least a phrase, so that whatever the little poorer outcome can be compensated by the resection. And again, pancreatic head mass, as I told you, is a key determinant to go for what type of procedure, whether it is a resection or drainage, and if it's a drainage, and we need to add the head coring or not. Distal CBD obstruction is one. If you have a good, one factor which we need to take into consideration, and two options are available. We can do isolated biliary drainage, or we can tackle it within the head, so that if you do a good head coring, we can open up the duct so that that can be tackled if the obstruction is purely because of the fibrosis secondary to the chronic pancreatitis. And no doubt, no questions, if there is a suspicion of malignancy, we need to go for a resection procedure. Before I go to the technical aspect, for pancreatitis, both for open and laparoscopic surgical interventions, please don't operate in an acute episode. That will be, we face a lot of bleeding, the anastomosis may not be perfect, our quality of surgery will be compromised if there is still an acute inflammation not settling. Some patients will continue to have a chronic inflammation. They may not have a baseline normal values, but still it's worthwhile to wait, give a course of complete pancreatic enzyme replacement, reduce the inflammation, and then tackle it surgically. And as far as the pain, I can confidently say surgery provides a long-lasting pain relief to the tune of to a 90% 5-year pain relief. And the general dictum is more you remove the pancreas, more pain relief. That's been the literature from open surgery. And that's why we have phrase procedure, which has a head coring, Beggars procedure, which is neck transection, or Whipple's, have better outcomes compared to a pure drainage procedure like an LPG. And as prior, I told you that please don't select the surgery based on the exocrine and endocrine function, diabetes, and the steatoria, because surgery has equivocal results. The general rule is 50% unaltered, 25% there may be worsening of the diabetes, 25% of or less than 25% may improve if we tackle it early. So because of these variable results, we should not suggest surgery for steatoria and diabetes. That's the evidence I've shown. Coming to the core area of my talk, that is laparoscopy for chronic pancreatitis. Even now, after 20 or close to 30 years, 3 decades of laparoscopy in place for abdominal surgeries, I can confidently say still it continues to be a no man's land. There are certain places where we have picked up late, like for example, liver resections. In the last decade, enormous work has been done in liver resections. Continuous efforts have been done for Whipple's procedure by laparoscopic or robotic approach. I can say a lot of such examples. Probably few caveats, few areas still needs to be covered completely by laparoscopy. Say, for example, portal hypertension surgeries. Surgery for chronic pancreatitis is one. Still, we need to do a lot of work. The general acceptance is less. people are reluctant, even now reluctant to embrace laparoscopy for some of the intra-abdominal situations. And I can confidently vouch chronic pancreatitis is still continue to be one of those last, I would say, hurdle or last mountain to be captured. Probably I'll enumerate why it is so. It is not by choice, because there were attempts, but because of inherent difficulty in dealing with chronic pancreatitis, that people are reluctant to venture. I'll start with a few issues. See, it's like a bead. We all know that in a ARCP picture, it's like a bead of beads, chain of lakes. There will be dilated portion, there will be a stricturous portion. The best, I would say, the area or the important, one of the important surgery where we require the bidigital palpation is here. We need to feel it with our hand, so that where the duct is, where the stricture is. So that kind of tactile feedback is not there in laparoscopy. So identifying the strictures and tackling it by laparoscopy is one of the deterrent. Opening out all the strictures is the key for the quality, good quality. And please remember the surgical option is only once. For the lifelong scenario, there will be only one time where the surgery for chronic pancreatitis is possible. The recurrent surgery is generally not so successful. If so, it can be done only for a malignant transformation. Resurgery for pain, recurrent pain is almost, I can say, is very, very less, even in open literature, more so for laparoscopy. So we have the opportunity only once to tackle it by surgical approach, whether it is open or laparoscopy. So quality of surgery is of paramount importance, like in malignant surgical interventions. So these are some of the difficulties: strictures, opening out all the strictures. But in laparoscopy, we can find out, slowly we can have our way of tackling these limitations, like opening up of the side duct, opening up of undrained segment of the duct. With perseverance, with a slow and meticulous surgery, what are all the limitations or what are all the difficulties which we thought are hindering the progress of laparoscopy in chronic pancreatitis can slowly be overcome. This is one situation where stricture with an undrained side branch or undrained main duct can be tackled with laparoscopy, provided we open all the branches. The next is usage of intraoperative ultrasound. Laparoscopic ultrasound has lot of function, lot of use in laparoscopy. One, to identify the duct. Second is to identify the stricture. Third is to identify the stone. And fourth is to identify the clearance or the completeness of the surgery. Because we don't have the tactile feedback, we don't know whether we have left a stone in the side branch or in the head or tail portion. For that, laparoscopic ultrasound can overcome some of the limitations. The next is side branches. It's not only enough. The main reason for pain post-surgery, both in laparoscopy and open, is because of the presence of stones in the side branches. We need to tackle the side branch stones as well. And for that, we need to be very carefully mapping. Even pre-operatively, we should say, as you can see, the main duct is open, but we have to seek for the presence of stones in the side branches. So preoperative mapping, preoperative morphological identification is very important. As you can see, the side branches as well as the uncinate branches have to be laid open. The stones have to be removed in order to have a complete and long-lasting pain relief. Here you can see main duct is open and we are trying to go into the side branches, even side branches having this kind of large stones. And other argument that is put forward for a lack of literature support for laparoscopy and lack of interest is head coring. People are afraid to do head coring because of all the arterial vasculature, arterial anastomotic branches by either superior or inferior pancreaticoduodenal arcades supplying extensively the head. And for that, we have devised a solution in the sense we pre-coagulate the head. As you can see, this is a nice bipolar forceps, Maryland type of forceps along with a vessel sealing device. We pre-coagulate the head or the portion where we wanted to divide. None of the energy sources is perfect here. So what we do is pre-coagulate nicely with a bipolar or vessel sealer, and then we core out the head. This is like using a pre-placed hemostatic sutures. You might argue that the same vessel can open up in the post-operative or even after head coring. And for that, we have a solution in the form of stay sutures over the core portion. So first thing is pre-coagulate, do a head coring, extensive head coring anterior to the duct, and then later at the sausage shaped head, we can have stay sutures or the hemostatic sutures, so that the blood vessels which is coagulated with energy sources can be tackled with the sutures. So this is again over a period of time. Initially, we have been doing lateral pancreatitis, LPG only. After that, we have added phrase or head coring in almost all the cases, even if it is a little one. So because the evidence have shown that adding a head coring definitely contribute to long-lasting pain relief. The other argument put forward for or against laparoscopy is the long winding anastomosis. Again, if you have known how to suture, Dr. Baiju is a master in suture. Dr. Manas is a master in suture. Both of them, they can suture in about, I think they can do a suture, do the anastomosis in about 45 minutes to 1 hour. So initially, yes, it was difficult because one trocar cannot have a proper suturing angle from tail to head. We need to have at least a couple of suturing ports for at least for the right hand, if you are a right-handed person, for a long anastomosis. But again, over a period of time with experience, this also can be overcome. But there are certain areas where lap is not so preferable, like the small duct. I don't prefer laparoscopy if it is less than 5 millimeter where I have to go in. So open surgery is still the best option. If it's complicated with the complete studded stone, as I told you, we have to nudge out all the stones from the lateral, small branches, from the lateral branches, from the side branches. I think hand helps or hand has an advantage. And also pseudocyst complicating chronic pancreatitis, like here, probably we need to change our surgical options intraoperatively, and we need to have an adequate drainage of pseudocyst also. So I prefer to go for open surgery if it's a pseudocyst or pancreas replaced by the stone. For the completeness of the surgery, as I told you, there is only one choice, only one opportunity for us to tackle laparoscopically, unlike an endotherapy where we can attempt multiple times. Coexisting malignancy, as you can see, is malignancy formed just above the stone or close to the stone. No question, better to go for open surgery, because we cannot rely on only the the laparoscopic findings as far as the malignancy is concerned. If you look at the Whipple's procedure, the first few Whipple surgeries are done for chronic pancreatitis, and Gagner concluded that he concluded in general that laparoscopic Whipples is not a good option at all, but just because he selected chronic pancreatitis as his case, not the malignancy, periampullary or the CA head of pancreas. And again, few studies have also subsequently have come that for head resections in chronic pancreatitis, laparoscopy is not a good choice. Even now, if I wanted to do a resection procedure, say coexisting malignancy, definitely we'll go for open Whipples rather than a laparoscopic Whipples. So coming to a subset of patients which are ideal for laparoscopy, I choose as you can see, this is a reconstructed image. You can see the pancreatic duct is thin, nicely atrophied. The duct is filled with stone, nicely dilated duct about 1 centimeter. So the moment you put a needle, you can see the pancreatic juice coming out. These are no portal hypertension, no engorged veins. These are an ideal candidate for laparoscopic approach. And if there is not much of a head mass or a head thickening or a inflammatory mass, probably this is an ideal for lateral pancreaticojejunostomy. The same scenario, if you have a slightly inflamed head or slightly thickened head or an inflammatory mass where we need to add head coring, probably these are head predominant disease, still we can do a good laparoscopic phrase procedure, provided the duct is dilated, not much of portal hypertension, not much of a splenic vein or portal vein thrombosis. Coming to the technical aspect, the surgeon stands between the legs majority of the time. The port placement is you put the camera slightly above the umbilicus so that you have a good view of the entire pancreas from head to head to tail. And we use 2 working trocars and 2 retracting trocars, so that generally we complete it by 5 or 6 trocars. When the surgery is proceeding, I would say PD, pancreatic duct identification, is the rate limiting step in laparoscopy when everything else is going smoothly. There are instances even with the laparoscopic ultrasound, we may not able to hit the pancreatic duct by laparoscopy because we don't have a tactile feedback. So in such situations, we have to open it. So I would always say, in a carefully selected patients, rate limiting step for laparoscopic approach is identifying the pancreatic duct. And for that, preoperative mapping helps, so that you should know where exactly to strike the or hit the pancreatic duct, whether it is close to the neck or away from the neck or in the body. You see the most dilated portion, there you strike. So preoperative imaging, preoperative mapping definitely helps in identifying and selecting the site of initial puncturing. Splaying open of the gland is very, very important. And I reiterate the point that the principles of surgery should not be compromised just because we are doing laparoscopy. And as I told you, laparoscopic ultrasound should be used. Stones have to be nudged. They are cleared from the main as well as the side branches. And palpate for stones if in open, but unfortunately in laparoscopy we cannot palpate, but we can use the tip of the instrument and also the laparoscopic ultrasound for clearance. The stone clearance, wherever, whether it is deep inside the duct, deep inside the uncinate process, deep inside the side branches, it has to be cleared for a long-lasting, comparable pain relief. I have, in a couple of instances, opened the case after identifying just because I felt that the stone clearance was not adequate. So yeah, ultimately, what is important is the quality of the surgery should not be compromised. You can see this is a large stone. So stone clearance from wherever, especially in an obstructing duct system, has to be cleared. This is one complete procedure where starting to end, I'll just, it's about a 7 minutes video probably. I can fast forward it. Here you can see the stone is predominantly in the head, dilated duct up to the tail of pancreas, and you can see few stone load in the body of the pancreas. Exposure of the pancreas is very important. Falciform ligament is stuck, and with the help, after doing a single incision surgeries and robotic surgeries, now we also learn to tuck or hook the stomach or other structures, so that the entire pancreas from, this is a right gastroepiploic pedicle. Sometimes it comes in our way, so it has to be clipped, divided, and move out of the field. So the pancreas should be exposed from head all the way up to the tail, so that we have a nice drainage, a nice opening of the duct. Here you can see the falciform ligament is stuck. There is no assistant retracting the stomach. The stomach is hooked to the anteroabdominal wall. The cattle brush maneuver of bringing down of the hepatic flexure colon is done. Cocker maneuver should be done as in open surgery. In fact, a wider Cocker maneuver helps us in exposing the head of pancreas. It lifts up the pancreatic head away from the retroperitoneum, so that like in open surgery, these are two important maneuvers: bringing down of the hepatic flexure colon, as well as I can see the Cocker maneuver is done like in Whipple's procedure. So this below is the IVC. The duodenum is lifted up, Cocker maneuver, extended Cocker if in case it's required, but at least head should be completely lifted away. So these are some of the key steps before we go and approach the pancreas. Exposure of the pancreas from head to tail is very important for, you can see placing a gauze piece behind the head will make the head more prominent, so that head coring or identifying the duct becomes easy. Now, this is no more a retroperitoneal organ. It comes into the intra-abdominal area because of lifting up, so that we can tackle these, the subsequent surgery becomes easy. As I told you, this is a preoperatively mapped duct, so we know where exactly the most prominent portion. We put the venous needle, you can see the gush of pancreatic juice, and then you will follow that punctured area. So use a combination of monopolar hook as well as Maryland forceps. Enter the pancreatic duct. The rate limiting step is now overcome. The stone, and then opening of, splaying of the pancreatic duct is now underway. It has to be from head to tail, and we remove the stone that comes in our way. Edges of the pancreatic duct along with the pancreatic parenchyma has to be carefully coagulated, so that there should not be any bleeding from the edge. It has to be coagulated nicely. So we then carry out the opening of the duct towards the tail. And by tail means we have to go all the way up to the tail, about 5 centimeters away from the splenic hilum. So again, there is no shortcut. We cannot leave any undrained portion. Once the tail, up to the tail we have gone, we come to the all the more crucial area of head. Again, as I told you, pre-coagulate with a good Maryland bipolar forceps to reduce the bleeding. You can see nice large stones being extracted. Open the duct, instead of try to nudge in, open the duct, automatically the stone will come. This is what I said, head coring. We coagulate, put a stay suture. In fact, Dr. Ramesh Ardhanari, H. Ramesh used to demonstrate, it's like areca nut. You shave in layers. Likewise, you don't go for bulk head removal. In layers, in layer by layer, we have to shave the head till we reach the, as you can see, we generally, I stop here, sorry. In laparoscopy, generally what we do, we don't go posterior to the duct. Sometimes the duct may be very thin, very close to the posterior capsule. We might make a complete through and through hole. So generally we restrict to the posterior wall of the duct. If in case you see the stone, we make a small nick and then remove the stone. Otherwise, all the head coring happens anterior. That's why even in our paper, we mentioned it as modified phrase procedure. So you can see the head is being cored, it's being made shallow. At the end of the procedure, it should look like a shallow well, not a deep well. If you are a deep well, that means more of the some more of the head is still have to be cored. So once this is done, obtain nice hemostasis. Keep some stay sutures at some 2 or 3 points along the open pancreatic duct. Then we'll go for a Roux-en-Y pancreaticojejunostomy. It's a generally we bring in a retrocolic fashion, and we open the jejunum slightly less than what we open for the duct, because jejunum is more pliable, more elastic. It can be stretched and then made anastomosis can be done. We start with a posterior layer, or I can say for a C's inferior layer. We start from the tail. The suture material which we use is 2O or 3O PDS, depending on the thickness of the pancreatic duct. this is again, if you plan the anastomosis properly, along with the help of the assistant, we can see good retraction, good anastomosis, good ergonomics play a lot in reducing the fatigue and decreasing the time taken for anastomosis. We might face difficult, this is the anterior layer. So we don't close the head portion. We come all the way and then stop it. Then we can continue the anterior layer from tail to the body. And finally, we come to the head. So this is head. Head portion sometimes may be difficult because of the angle. Like you can see the reverse passage of the needle. This requires some training, and also some of the pancreatico-duodenal arcade blood vessels can open up, can be hit by the passage of the needle. So you need to take hemostatic bites once in a while along the cut margin of the pancreatic parenchyma to reduce intra as well as postoperative bleeding. So generally we prefer a single layer anastomosis posteriorly, and anteriorly, since we have access, we can do a double layer closure, especially the cerebromuscular closure for anteriorly. You can see a stone is nudging out. So with the assistant keeping a traction on the suture, continuous suture, we can do it in a relatively quicker manner. So that completes the anastomosis. And then this jejunal loop has to be hitched to the duodenum so that it maintains a perfect alignment, a tension-free anastomosis, and also in perfect alignment so that the entire duct, open duct, is drained. This is the jejunal anastomosis to complete the GI continuity. As I told you, it's a road definitely less traveled. Even in 2020, not many articles. When I searched for laparoscopic phrase procedure, 32 articles were shown. And if you look closely, out of which at least 50% are for various other procedures not related to phrase procedure, and LPJ hardly 40 procedures. Again, if you filter it, hardly 50% only it will come. So basically, we have less number of articles in this, all the more important, especially from the Indian point of view. Look at the first UK experience that happened only in 2004, and even look at the number of patients. And all the literature had only a handful of patients. Majority of them are less than 12 dozen patients. Our experience, that's why I restrict myself to our experience. Initially in 2006, we published our initial experience with 12 patients with the mean PD diameter. You can see 15 cm. We were very selective in our initial approaches, predominantly lateral pancreatic jejunostomy, and the operating time is about 3 hours. And what is important is you can see hospital stays less, and complete pain relief could be achieved in about 83% of those highly selected patients. That was our initial experiences in a highly selected patients published in the year 2006. After that, this was the paper which Dr. Baiju quoted while introducing me. This was published last year. To our knowledge, this is the largest published series of laparoscopic management of both phrase as well as pancreatic modified Pusto procedure. And we took, you can see from 2006 to 2019, we took 13 long years to analyze our results. And then these are our results. The number of patients is 54, which included 39 of the LPJ, and the remaining is a phrase procedure. And both are comparable in the sense the hospital stay, duration of surgery is little longer in phrase procedure for obvious reasons, but the rest are all comparable. And any surgery for chronic pancreatitis is always it goes for pain relief. That's why I have compared this, taken this table. You can see we have compared in this particular paper our pain relief both for LPG as well as for phrase procedure at 12 months, at 3 years, and at 5 years. And in all the duration, either it's 1 year, 3 year, or 5 years, you can see the pain relief is quite good. In the sense, you can see at 5 years, the pain relief is approaching 90%. You can see 88% of the patients had a long-lasting pain relief at 5 years after surgery. So this is one of the important paper which stresses the importance of laparoscopic approach for chronic pancreatitis. And instead of few patients, this number of patients is about 54, which is though not in hundreds, but still it's substantial to arrive at a reasonable conclusion that laparoscopic approach for chronic pancreatitis can also produce a substantial long-lasting pain relief. And this is the paper. This is again 47 patients. Before this article came, this was published in the Asia Pacific IHPBA by one of the author, Vikram. Here you can see the GEM study compared with the majority of the open literature starting from 1994. The operative variables, the blood loss, morbidity, and mortality again is very favorable with our study. Not much of a great blood loss. And when compared to the pain relief, because not much of a comparative study exists in one single paper between open and laparoscopy, that's why we have taken some of the, compared with some of the best available open literature as well. Right from Frey himself, Isbeki, these were the pioneers who have published their reports. And when we compare our series with those of those doyens of surgeons, surgery for chronic pancreatitis, we could able to see that pain relief, weight gain, the diabetes, everything is comparable with that of the best papers that are available for open literature. You can see the long, at that particular 47 patients, it's 85. And we have added around a few more patients, and then this present paper showed 88% of pain relief at 60 months, that is 5 years. So this paper, one of the seminal paper, I can say one of the largest, have shown that it produces a long-lasting pain relief. The other two important papers which I have to acknowledge is one by the moderator, Dr. Manas, who did laparoscopic pancreatojejunostomy, lateral pancreatojejunostomy, and he employed a novel technique of putting the flexible scope so that the main duct stone clearance is not compromised, and made sure that because of the usage of the flexible scope, the stone clearance is completely ensured. That's a very novel technique we also used in some patients. And a very early series from Om Tantia from Calcutta, he also published a series of laparoscopic LPG. So these are some of the Indian publications in this particular field, but nevertheless, we have to accept that the literature support is far and few. There are other literature, options that are available, though out of scope of my talk. Still, I wanted to mention, like total pancreatectomy with islet cell transplant in a select set of patients, especially hereditary pancreatitis, and along with the coexisting malignancy, or chronic pancreatitis with diabetes, where an islet cell transplant can have a good relief. Along with the pain relief, they can also go in for good control of the blood sugars. So these are now new developments. And we also, I wouldn't say this as a new development. These are some of the additional advantages of minimal access surgery. We also published the single site lateral pancreatojejunostomy. This is to show that those people who feel that it's a long anastomosis, difficult anastomosis to make, difficult to nudge out the stone by laparoscopy. This paper is just to show that even with single incision or single incision multiport technique, still we can do a good job by lateral pancreatojejunostomy. If not this, at least by multiport technique, conventional laparoscopy definitely we can achieve as good as job as we do it in laparoscopy in open surgery for select set of patients. I'm a proponent of laparoscopy for chronic pancreatitis in select set. My case selection is, case selection is very, very stringent. On any given day, my case selection for laparoscopic Whipples is far more relaxed than laparoscopic approach for chronic pancreatitis. But nevertheless, the point I like to make is there is definitely subset of patients in chronic pancreatitis which can be amenable by laparoscopy, and we should not miss out on those patients just because we feel that there are inherent difficulty in managing those patients. So my conclusion for laparoscopy in chronic pancreatitis is definitely it is technically demanding. I also mentioned the limitations and the ways by which we can overcome those limitations by perseverance. And laparoscopy, yes, it can be used in highly selected patients, predominantly dilated duct, stone load is big, not much of an inflammatory process, not much of a head disease, and especially young patients, this is an option for chronic pancreatitis. And I have to acknowledge the fact that literature is limited, far and few, but whatever the literature, limited experiences, including our own publication, have shown that at least equal results when it compared to the long-lasting pain relief at 5 years. So it has definitely it's fine, useful for subset of patients, and we should identify them and offer them the laparoscopic approach, and that is my take. So with this, I conclude my talk, and once again, I thank Senadhipan Education Foundation and Dr. Baiju for inviting me to share some of my experiences in this chronic pancreatitis. And I also wish all of you to stay safe and stay indoors, tide over this pandemic, so that we all live long to serve the poor, serve the people. Thank you very much.
Thank you, Dr. Senthilnathan, for the wonderful talk. The videos were fantastic. Actually, it was very clear also because we muted the videos of the participants, so the videos came very nicely. As you said, there are only a few publications available in the literature. Actually, if you count the number of cases done as per the literature, is less than 100, in fact. So, and that majority of the publication is from India only. So, with that words, it's my privilege to acknowledge the participants. There are a lot of dignitaries come as participants. May I introduce them to the forum. Dr. Punidhar is there. Dr. Anandakumar from Trivandrum, Dr. Shubhalal from Trivandrum, Dr. Sinthu from Trivandrum, Dr. Sudhir from Kochi, Chirag Desai from Ahmedabad, Dr. C.P. Kothari is there, Dr. Parveen Bhatia is there, and Dr. Prathapan from Calicut. Lot of other people which, because the name is given differently, I cannot acknowledge. So please stay with us for the discussion. I will not unmute you now, but for the discussion part, I will be unmuting you. Now I give the mic to Manash Ranjan Sahu.
So thank you, Baiju, and thank you, Senthil, for that wonderful disposition of chronic pancreatitis. In fact, your last slide was the clincher. Chronic pancreatitis, I think for the last decade of my small experience in this disease, managing laparoscopically, has always been a deterrent for many surgeons. Surgeons always think that chronic pancreatitis at least should not be handled in a laparoscopy way. As you rightly told that selecting a case for chronic pancreatitis is the whole bunch of the main cue at the surgeon can take it for the good result. Unless the case is selected properly, probably your all this maneuver and all this exercise might fail. So as you, Senthil, were telling that regarding not having much of head load, not having head inflammatory mass in the head. In fact, when I started off doing laparoscopic surgery for chronic pancreatitis, one of my criteria was, apart from a dilated main pancreatic duct of nothing less than 10 to 12 millimeter, the other criteria I was always using CT evaluation wise, the dimension of anteroposterior dimension of the head less than 3 centimeter. If it is more than 3 centimeter, I think he is a candidate who should undergo phrase always. I mean, I never compromise on that. And initially, if a surgeon wants to start a laparoscopic surgery for chronic pancreatitis, and if he thinks that he'll be starting off with phrase, probably he can never do it. From my small experience, I could understand that if you are going to start your surgery for chronic pancreatitis, we started it with first assisted procedure, then LPJ, and slowly we upgraded to phrase. And as you rightly told that it's always better to pre-coagulate them. I just want to have another idea to that in addition to pre-coagulation, as we use hand in our open surgery. So what I was doing that I'm using a liver retractor from the right flank, and that goes and stays behind a mobilized head of the pancreas, and it acts almost like a head of the surgeon, I mean hand of the surgeon. So that is one thing I just wanted to technically add to your presentation, Senthil, that how I am just over a period of years, we could know that how we can handle this. Because many a times, if I tell that, yes, this can be handled, phrase can be done laparoscopically, people think that how are you going to handle the head as we are doing so comfortably on open surgery with your hand placed behind the head. I mean, you can mimic the same thing, putting a 10 mm liver retractor behind the head, and it is when it is well mobilized, you can do things much better, and almost every precaution of and everything that you are doing in open surgery can be mimicked as also in laparoscopically, and it gives a lot of comfort to the patient. When in fact in an open surgery, even with a phrase, we are not able to assure him 100% of the results. Why not do it laparoscopically only in selected group of patients, not in everyone? I mean, small duct disease is always a big challenge. I think Senthil will also agree to me that we should never ever try and get our things done in laparoscopically. And more so, I am also a little bit hesitant when stones are there in the uncinate process of the pancreas. Probably when it is there in an uncinate process, when the MPD is not gross, I mean not dilated well, and if the head mass, I mean almost everywhere where our main intention is now is to do a phrase. So in this scenario, we always hold back. We do not get tempted. So essentially, I think choosing surgery laparoscopically can always be done. And we can almost, as Senthil has nicely told in his last paper, that results are almost akin to what we get in an open surgery. So I think before we open up questions, Baiju, can we invite the audiences to post, to appear and post their questions?
They can themselves open the video.
Okay.
And we will unmute them once they raise their hand.
Okay, fine.
I think Dr. Manas has summarized so well in all the points which I mentioned, and also pointing out few more additional things like how to graduate from beginner to expert in chronic pancreatitis.
I have one or two questions, Senthil, for you. When I do phrase procedure, not LPJ, not Parkinson procedure, phrase procedure, I add two more steps. One is a tunneling, as you do in laparoscopic people, so we do a tunneling, and I keep a gauze piece between the portal vein and the parenchyma. So when you do a coring of the head region, there should not be any injury to the portal vein or the adjacent splenic vein. So that's an additional point which I, for safety only. And cauterization is done for not only for lifting up the head. Actually, cauterization must be mandatory for controlling the bleed. If at all, sometimes you may have to open. We had situations we had to open urgently. Then you will not get time for controlling the bleeding after cochlearization. So already the cochlear duodenum is there. You can lift up and control the bleeding if it is, if at all, if it is there. So that is the second step I add to it is that gastroduodenal artery. Just identify the gastroduodenal artery. Don't do anything for the gastroduodenal artery. Just identify the gastroduodenal artery. Sometimes the bleeding can be stopped by ligating the gastroduodenal artery. So these two steps I usually add to a phrase procedure, not a Parkinson's procedure. So the other things which Dr. Senadhipan told is absolutely right, and this thing can be, or probably can be modified like that. Yeah. Dr. Manash, can you open the chat box and read each one?
I think I just, before I open up the chat box, I also agree, Baiju, that's a good take of putting a gauze piece between the portal vein and the tunnel just for the protection point of view. That's a good thing, I mean, technically. And other thing, in fact, Senthil, you rightly told that graduating over the procedure, I mean, if a surgeon wants to start off chronic pancreatitis laparoscopically and jumps in to do a phrase, probably he will fail and he will tell that this is the end of the game. I should have never proceed and do a chronic pancreatitis. And that
actually, the number is less, not because the cases are not there. It's there, but because the technical feasibility, the technical difficulty, the cases are less.
Absolutely, absolutely. So there are some questions from the chat box. There is a question that do you do frozen examination of pancreatic tissue cord to rule out malignancy? From Dr.
Manash, you can read out each and every, even if it is a greeting, even if it is a this thing.
Okay. Oh, even if it's a greeting, right? Okay, fine. Just a minute. Let me start out from the beginning. But I think Dr. Anant Narayan from Gut Club Cochin has conveyed his greetings to each one of us. Thank you, Dr. Anant Narayan, for your greetings.
He's a senior medical gastroenterologist in Cochin.
Okay.
Thank you, sir, for joining us.
Thank you. We also we appreciate your appreciation for the program. That's good. Dr. Ranjit from Dubai has also sent his greetings. And Dr. Puneet, Puneet is doing wonderfully well in Rishikesh AIIMS. So he has, I mean, appreciated Senthil for your excellent presentation and a very balanced presentation. In fact, Senthil, as always, is always balanced in his presentation as well as in is otherwise. So from Manoj, nice discussion, sir. Thank you. And from Puneet again, best wishes. He's probably has to go somewhere. His flight is taking off. And from Murilo Utrini, thank you for all the great class. That's a greetings again. Thank you. And Dr. Ranjit Kumar, very good presentation. He has appreciated your presentation, Dr. Senthil. And Dr. Iswaramurthy has appreciated Baiju's video presentation, I mean presentation of Dr. Senthil, and it's great to listen to all interaction and great to know many stalwarts today. Good luck with all your academic endeavors. Iswaramurthy has appreciated your effort, Dr. Baiju, for these academic endeavors. And there is Dr. Wanjara, great presentation, very informative and trailblazing advances. What do you use to map the PD pre-op? Senthil, I think Senthil has clarified it. He uses an intraoperative ultrasound. In fact, you also agree with me, Senthil, that even if somebody doesn't have an intraoperative ultrasound, since we are picking and choosing selected cases where at least 10 to 12 millimeter the PD is there. So if we even palpate with your Maryland, we can know that this is the softer part of the parenchyma, which is a duct. And you prefer a varus needle and I prefer a spinal needle. In fact, 18 gauge spinal needle, just to prick prick into that duct and aspirate, confirm that this is the PD. So you agree to that? Even some surgeon doesn't have an intraoperative ultrasound.
It is not a must. It can sometimes use as an adjunct. But you rightly said, dilated duct definitely will, with the tip of the Maryland, you see the texture change.
The texture will always vary. I mean, as you feel the parenchyma and the duct, you can always feel. And with a few more cases, you will surely have a feeling as if your hand is there on the pancreatic duct.
And to your point, I also use a spinal needle. If in case it's a very wide duct, then
you use a various. Okay,
yes.
fine.
It's
fine.
Perfectly okay if you use a spinal. In fact, I also, if given the choice, I use a spinal needle because it's a thin. Even if it's a vessel, it doesn't do much.
Doesn't matter. That's
directly. Sometimes posteriorly, sometimes I have aspirated blood, meaning that
with a spinal needle, nothing to worry about. So I prefer all the cases. I always pick up a spinal needle to do it, and it's very comfortable.
Correct.
Great.
Dr. Sindhu has raised her hand. Can you unmute Sindhu? Dr. Sindhu, can you unmute and say something?
Dr. Sindhu is in Trivandrum Medical College.
She has shifted to Kim's Hospital. She has a lot of research in chronic calcium pancreatitis, in fact. And she has some papers also.
I think we, the Indian surgical community, surgeons who do a laparoscopic procedure for chronic pancreatitis, we should have a registry and then try to pool the cases so that we bring more number of cases, say a few hundred cases. Dr. Baiju, Dr. Manas, or anybody especially in Kerala. I know one Dr. Pravin Suryavanshi is doing at Aurangabad. So a few Om Tantia. So these are some of the people who are doing surgery for chronic pancreatitis by laparoscopy. We should pool.
Actually, I have completed 17 cases, and four of the cases were demonstrations in conferences.
Yeah, I have seen one. They're beautifully demonstrated.
Yes. Sindhu, you can unmute and tell us. Yeah, hi.
Am I audible?
Yeah, you're audible.
Okay, I have two questions. Very nice presentation, very inspiring as always. I have two questions. Am I audible now? I just closed my video. Actually, one is regarding this precoagulation. Will it affect with the histopathological examination? The second is regarding your tips in exploring the uncinate duct.
Okay, the first question is precoagulation is done at the area where we are dividing it. Above that, superficial to that, there will be the tissue will not be charred. So even though we do in slices, there will be a dead tissue at the point where we divide it, and above it there will be a live or tissue which can be subjected for histopathological examination. It's not like complete, say for example, Habib probe in liver surgery, it's like complete ablation. We are not doing that one. Only about a millimeter or 2 millimeter of the transection plane or a dividing plane, we precoagulate. And then if you look at my video also, above it, where I have taken the stay sutures, surrounding that will be a tissue which can be subjected for histopathological examination. Uncinate duct, one of the difficulty areas to access. The best thing is after coring out the head, make sure that the head is shallow. Then we have to go for the uncinate. So uncinate duct generally is done lost. Once everything is shallow, becomes shallow, because in the deep one, the main duct curves into the uncinate. That will be very difficult to, even if there is stone, we tend to do it after removing the head. Coring, then you tackle the uncinate, it becomes easy. That's the tip for uncinate.
Okay, nice. Thank you.
I think that
Manas,
no, I just was adding to that areca nut thing was the best example of charring and excising. So as you slowly char and slowly go on excising, so you don't burn out more tissues, and in fact your histopathology will never be affected at all. And quite often,
one is areca nut, the other one is since a lot of people are from Kerala,
like banana. And quite often we have so nicely chosen these cases that we have almost ruled out any evidences of malignancy along with tumor marker study as well. So in fact, You agree with me, Senthil, for this?
Yeah.
So
there should not be any doubt about
yeah,
the
absolutely.
absence of and presence of malignancy.
Absolutely.
Without then surgery by open is better.
True.
Still, we don't know whether we cannot be 100% sure. For that purpose, we send these head code out pancreatic for histopathology.
Agreed.
And Dr. Prathapan has done a lot of open surgeries for chronic ulcerative pancreatitis in Calicut. Actually, he has got a very good series of cases. Dr. Prathapan, do you have anything to ask, or do you have anything to add?
Nothing to add. Very nice presentation, Dr. Senthil. I think most of the time we were looking for a laparoscopic demonstration of stress procedure or LPJ, but we never saw one in a conference or a live workshop. Your video on lab was excellent. So I have three things to add, not add, it's to comment. As with open, when you do surgery for an undilated or minimally dilated duct, the pain relief is not that good. So if you compare both laparoscopy and open, sometimes you may have improved result in laparoscopy, because in laparoscopy there is a definite selection bias, because we do select cases which are easy to access, easy to remove, and easy to anastomose, rather than we do cases undilated duct where identification of duct is very difficult, and most of the time we had to start from the head and go towards the body tail region, because then only we can identify the duct in most of these undilated cases. So I think if you compare the total number of cases, I think you will have better pain relief on laparoscopy. If you have to say you have done 100 cases, and of which if you compare undilated duct, the pain relief will be poorer for open cases if you don't do a complete trace.
Yeah, definitely, yes. These are not exactly case-matched comparisons. There will be obviously be some bias, because more dilated duct we choose for laparoscopy. In our center, the one paper that is in preparation stage is case-matched comparison. Say duct above 7 centimeters. 7 centimeter for me is the cutoff. Though even though in open 5 millimeter also can be taken up in open, but for laparoscopy we generally restrict to above 7. So above 7 in open and laparoscopy we have compared. There also the pain relief is almost the same between the two groups, open and laparoscopic surgery. So for me it's a non-inferiority. At least it's as good. I'm not here to say it's superior, but at least
there is no head-to-head comparison between open and this thing. Actually, he
not possible. That is what.
Absolutely. And for the first question, but in fact, Dr. Baiju said he demonstrated 4. I demonstrated in 3 places. If you remember in Pune,
I was sharing the session.
Yes.
I asked you one question: are you happy or not?
No. I remember when I was trying to open, you just frightened me that it looks like a splenic artery. That I was. Then I have to really again search for some more time, see the splenic artery. Even you were cautioning me that it should not be a splenic artery. I hope you remember that one.
Yeah, I remember.
Yeah, then I double checked. It is not splenic.
I have one more comment, Baiju, regarding the role of surgery in asymptomatic chronic pancreatitis patient. There are so many papers coming on long-term follow-up of chronic pancreatitis patient, where a larger stone load has got a direct relationship with development of malignancy, as with you see in gallbladder stones when the stone size is more than 3 centimeters. So even if the patient is asymptomatic, if you clear the entire pancreatic duct and pancreatic head with stones, that will be a better, give better long-term outcome regarding the malignancy. Any opinion on that?
I totally agree to your point, Dr. Prathapan. Definitely, especially I think one of the largest series is from H. Ramesh Center, wherein asymptomatic, large stone load patients can be subjected for surgery to reduce future complications. We are there. We are just reaching there. Probably we need few more evidences to say that we can operate on asymptomatic patients with a huge stone load. At the moment, yes, I agree to that. Even literature is slightly less, but I agree to your point. We need to tackle those big stone load. I have a few patients under follow-up, big stone. The entire pancreas is replaced like a cast with stones. And more importantly, retrospectively, if you look at the malignancy developing in chronic pancreatitis, majority of them will be with a big stone load. In our series, it's about 5 to 10% long-term follow-up. Those patients who have big stone load, very hugely dilated duct, they have increased chance for developing malignancy. So probably the stone is an irritant to the duct mucosa that probably contribute to the development of malignancy. Still the literature is forthcoming, but nevertheless, at this point of time, I will not be averse of doing, if the patient is especially willing, that to reduce. Convincing the patient is an issue because it's not a simple procedure. We need to convince them. But if few more, that's why we should all be publishing our data. If a few more studies are forthcoming, then probably we can recommend it as a routine one, that with big stone load, asymptomatic also is should be done. But we are just reaching there, not yet fully there. That's my take.
But Senthil, at the same time, you will also agree to me that the happiness index of a patient who is symptomatic and has undergone surgery, and the happiness index of the patient who is asymptomatic undergoing surgery is surely, it varies.
Definitely differs, yes.
It always varies.
In fact, the patient will be craving for surgery because they have been.
I mean, those patients, they respond best, and they always have more of gratitude for the surgeon and for the surgery.
Exactly.
And
very valid point.
Yeah.
Convincing a patient in asymptomatic will be the
very difficult.
Absolutely,
the onus is purely on us.
Post-operative.
He doesn't understand that there is a malignancy risk that you are doing it. And he doesn't understand that you have taken all the pain of doing it laparoscopically.
This is like a bariatric surgery.
Yeah, absolutely.
Bariatric surgery,
true.
People think that we are
normal people. We are normal people.
For any benefit. True. Likewise, asymptomatic patients, convincing them will be difficult. Any post-operative small issues will also be difficult to manage.
Always.
But nevertheless, if the evidence is very straightforward, forthcoming, then probably we can.
We can always push them forward. True. Otherwise,
Dr. Chirag Desai is there as joined from Ahmedabad. Can you unmute and tell something?
Senthil, I really appreciate the presentation. The videos were very clear, and I don't have experience of laparoscopic LPG myself. I do mainly open, but today's video and lecture was very inspiring. So probably that is something to venture onto.
Chirag, good evening. You are not visible.
Good evening, Dr. Chirag. Nice to see your voice.
Yeah, it's good to see you. Right.
Yeah.
Hi. Good evening.
Yeah, Lashmi Kant. Lashmi. Yeah. You are
Hello, sir.
Yeah.
So as usual, I think excellent presentation. And usually the suturing such a long presentation, sometimes it becomes difficult. Otherwise, for Senthil, I think it's easy. So I think very good presentation. Thank you.
Thank you, Dr.
Actually, very difficult to do a backhand suturing at the head end. Actually, when you come to the head end, actually you need to have the forehand and backhand suturing alternatively. Is it not, Dr. Senthil?
Yeah, exactly. See, it is not the difficulty of the suturing, it is the difficulty of the angles. At
Yeah.
body, at say 3-4 centimeters, you'll be comfortable from a particular port. When you come to the head or to the tail, as you rightly said, reverse bite, sometimes we need to take, instead of pronation, supination, we need to take. Or sometimes, I'm an ambidextrous person, I have to take with my left hand. So head is the difficult area. In this point, one trick is, please don't hesitate to put one additional trocar if the angles are not proper.
Also, your position also, if you are standing between the legs of the patient, you can shift to the right of the
Right side of the patient. Absolutely right. Absolutely. Shifting the position or putting additional trocar definitely saves a lot of time and energy.
May I ask Dr. Mohammed Salim sir to unmute his mic?
Sorry.
Yeah, sir.
Am I audible now?
Yeah, you are audible. Now your mic is mute mode. Now your mic is in mute mode. Can you unmute again?
Yeah, am I audible?
Now you are audible.
Okay. Baiju, I don't have personal experience to add to that or anything, but I must first of all felicitate Dr. Senthil Kumar for the excellent presentation. I just want to add only a message when the cohort question of whether to operate for symptomatic or asymptomatic. The word coming to my mind is about albatross syndrome, where albatross syndrome, you might have been aware of that word historically, albatross bird following an ancient mariner's ship for all the time clinging onto the poor surgeon who has operated on an unindicated case. So asymptomatic, there is a nice quotation saying that for any surgery, patient has to end his surgery. So my plea as a person not frequently operating on pancreatic by this phrase technique or those things laparoscopically, my only suggestion as far as a general surgeon's purview is concerned, the patient has to end his surgery by symptoms than operating prophylactically wherever possible. And this is applicable also to pancreatic jejunostomy procedures and stone removal procedures. That's the only comment which I want to add to that.
Thank you, sir. Thank you for the comments.
That we also told the same thing, that if he is asymptomatic, surely we is not going to accept for any small complication that might appear post-operatively. It's very difficult to convince the patient, because one who is begging for surgery, it is much easier to convince, and he accepts and shows the gratitude to the surgeon as well as for the surgery. It's his point always well taken. I think that's a common principle for every surgery. But if the statistics and evidence will come up in favor of this, probably it will be much easier for us to push the surgery on the patient, because the evidence shows that you are going to suffer from malignancy in a long run. That's the whole point.
Professor Prasanna Kumar is there in the audience. Can you please say something, sir? I think his net is not good actually for the voice is not audible. And there are a lot of people. Dr. Shubhalal is there, who was my professor. Actually, he is in the audience. Sir, you can unmute your mic and say something.
I think Baiju, Praveen Bhatia sir also will be interested to put a few comments.
I was checking his name, but he's not visible here.
Oh, he is very much visible. He
How
looks
can
so
it be?
handsome on the screen.
But I must give compliments to all three of you. And I would request Dr. Senthil, if you can share some of your complications and the lessons learned. Dr. Senthil, excellent presentation, as always. But is it possible to share the set of complications and the lessons learned?
Definitely, sir. Complication, first is bleeding complication. Especially after adding the phrase, initially our majority of laparoscopic work is Barrington procedure, LPG only. At the time, we didn't encounter much of a bleeding because we cut open at the edges. If you have a hemostasis, and also that will be included in the anastomosis, in the bite. So bleeding episodes were very far and few. But after adding head coring, we had few bleeding episodes in the post-operative period. In fact, 2 patients we have to go re-intervene, and again after some time again re-bled. So double intervention for one patient and single intervention for the other patient. In fact, I was personally upset in spite of doing a nice job by laparoscopic, then because both of them had to be opened. Then we realized this pre-coagulation will stop the bleeding at that point. Post-operatively, when it gets digested, it opens up. So then we realized that we need to add hemostatic sutures at 3-4 points along the chordate head, especially the superior aspect, superior pancreatic duodenal arcade, inferior pancreatic duodenal arcade. Even open surgery we encounter, but we suturing a bleeding point in open surgery is very easy, but in laparoscopy it's difficult. Even small bleeding can cause a lot of messy field. I still remember, sir, when we were in Kolkata, you said the best for demonstration, you should not have any blood. For it, this was a lesson you told me for my hernia surgery. I still remember, I still will not forget your advice to me. So likewise, it's always good that we prevent bleeding, but if small bleeders can be tackled efficiently by open, but not so in laparoscopic surgery. So we try to avoid, but we have to take, especially in head, we have to take at least 3 hemostatic sutures at the chordate area. By that, we could able to stop the post-operative bleeding. The second thing is, if you encounter, probably that was also shown, ligation. Ligation, there is a Fry's procedure, probably that also can lead to less post-operative bleeding. The second complication which I wanted to mention is, it's a long anastomosis. So the root limb has to be very tension-free. In a couple of cases, after the anastomosis is done, so 1 hour, 15 minutes later, then I found that the entire jejunum is dusky. So in one patient, I had to undo the anastomosis. The other patient, somehow, with the release of the mesentery to some extent, it came out, still not normal.
I wanted to add one more point in that context. Actually, while doing the anastomosis, I actually marked the anti-mesenteric border beforehand opening the jejunum, because while doing the suturing from the tail region to the head region, there can be twisting of the jejunum itself. So to avoid that, it's better always to mark with the cautery on the anti-mesenteric side. Otherwise, that can go and take a bite from the mesentery itself.
Yeah, these
you would remember that I always mentioned at that time also in Calcutta that surgeon is the best clotting factor.
Yes, sir. Yeah. Definitely, sir. 100%. These are the sayings and the teachings which I never forget.
Thank you.
Yeah, anybody having a question? There is a question for me actually. Dr. Durirajan Swamashekhar is asking, that is about tunneling.
Before Dr. Baiju, before you answer, I also totally agree to his point. I really had reluctant to go under the pancreas and do the tunnel. I'm afraid. His point, I agree.
What I am saying is, if it is doable, do it.
Okay.
If it is not doable, don't go there.
Right. Rather than the tunnel, what I follow is the inferior edge of the pancreas, the splayed out duct, and then the inferior edge. I try to follow that in the uncinate. You are right. At the uncinate, there is every possibility either at the uncinate or at the neck, we can hit the portal vein or superior mesenteric vein. But if you are in the confines of the inferior border of the pancreas, at least you will not go lateral. In the depth, we might hit the portal vein, not laterally. One good thing is if you're slightly trying to hit or made a small hole, we can suture through the depth of the gland, not at the lateral edge.
Yeah, without taking the posterior wall.
Yes.
Without taking the posterior. So that's the answer to Dr. Durai Rajan. Any other questions from the floor? Actually, we had 155 participants. Usually, we will be having 200 because it's a dry subject. Actually, people don't like to enter into.
I told this is a very highly subspecialized one. Unlike
we had 155, that's not a small number. Actually, when you take the entire Zoom analysis, we'll be having means 155 into 4 people, because some of them will be joining through link. So
no, Baiju, that proves that it is road less traveled.
That's right, sir. Yes.
And Senthil, you'll agree also regarding that bleeding part. I usually prefer to take preemptive sutures, 3-O-Prolene on the head, on the margin. Even you take 3, I prefer to take 5 or 6, all around preemptively.
Yeah,
so
more
that,
the better. More the better.
Yeah, more the better. And that in fact adds on and gives much more confidence to you that before you have started coring the head.
Yeah, yes.
I think Dr. Kuribula is there from Trichur. He has done a lot of, actually, while he was with Dr. HMS, and after that also doing lot of head coring procedures for pancreatitis, the CCP. I think he is there in the audience. I am not able to locate him.
Baiju, Professor Prasanna Kumar Dutta sir, he is there in the audience.
I called him, but
I think he was the head of the department of surgery in my previous medical college when I was doing their LPJs, lab LPJs. Sir, could you unmute yourself and speak something? He is presently heading the department in KIMS in Bhubaneswar.
He is already unmuted. You can say something, sir.
Yeah, he is unmuted, right? I think there is some network issue. Maybe he is not able to. Yeah, maybe.
Area.
Yeah.
So I think now it is the time for concluding remarks. If there are no questions from the floor.
I think we have covered all from the chat box as well.
I am also seeing most of it is covered.
Yeah.
Yeah, Chirag is asking some questions. Chirag, do you want to ask any more? There is a question from the chat box. Who? Salim sir, you want to speak something?
Yeah. Finally, am I audible?
Yeah, you are audible.
Yeah.
Dr. Baiju and Dr. Senadhipan, for postgraduate purpose, when we are theoretically asking what should be the take-home message as far as the dimensions are concerned, you mean to say that if the duct dimension is above totally, we will be on, and the situation is favorable only, then we can do this lateral laparoscopically and in open. And, and the other thing, the moderator was pointing out about more than 3 centimeters. One should not think of the lateral. Am I right in concluding like that, or is there any clarification from Senthil's side, or from moderator's side, or from Baiju's side? That's the only thing which I wanted to clarify.
Sir, I'll start answering. Initially, as a beginner, we ideally like to have more than 1 centimeter duct for easy identification and opening. At this point in time, my minimum diameter is 7 millimeter, but definitely I will be unhappy doing a laparoscopy at 7 or 8 rather than 10 or 12. More dilated duct is better. And as far as the thickness, there are some papers also with regards to the thickness of the head. Head coring is required if it's more, thick and the anteroposterior dimension, because that gives an approximate measure that side branches. Why the main purpose of head coring is we are tackling the side branches in the head, predominantly in the head, so that those calcification by means it's always it's a side branch stones. It's not a parenchymal calcification. What we call it as parenchymal calcification is side branch ductal stones. So majority of them in uncinate and head. So we try to remove. And if it is too thick, then probably open head coring will be ideal, because we have to dig deep into the parenchyma. So these are some of the points which 3 centimeter is good. 1 centimeter duct is ideal for the beginners. That's my take.
I think I just want to add onto that Dr. Salim sir, when I started doing laparoscopy for chronic pancreatitis, I was very finicky for choosing cases nothing less than 12 to 14 millimeter MPD, not at all, and nothing less than more than 3 centimeter head dimension. I was never picking them up. So it was extremely selective, and I started off with the assisted procedure. Slowly, as you go on doing, I could know that yes, even 10 millimeter also, or 10 to 12 is a very good and comfortable dimension where we can go and do it. But I think our acceptance level for open surgery also should not die out well. I mean, we should always be open to do open surgery if at all we feel that yes, the head dimension is quite high, head load, stone load is quite more. The more of stones in the uncinate process. I think there I am also, till now, I sometimes feel open is far better than attempting it laparoscopically and spending that amount of time and energy for the procedure. I think you agree to that, Senthil, probably.
Very, very selective.
Yeah,
so
very selective.
The success of laparoscopy in chronic pancreatitis lies
in case selection. Yes, absolutely, absolutely.
Yeah. Chirag was something.
My question is to Dr. Senthil. What is your strategy for associated bile duct stricture, and how do you deal with it? Whether you drain within the pancreas or you do separate HJ, or how do you deal with it?
Chirag is actually going to present a topic on HCC on 13th of September. So be prepared for hearing his lecture also. Yes.
See, for duct dilatation, biliary obstruction, my first preference is the same ruling can be taken, and then we can do a anastomosis. Or sometimes while coring out the head, especially close to the pancreatic duct, the duodenal margin, the duct, the bile duct itself, it opens up. If that is the case, we can do an intraduodenal or intraluminal drainage. Most of what we can suture the opened up bile duct to the parenchyma, so that we like the duct, the pancreatic duct is splayed open. The bile duct is also splayed open in the cored out portion. If accidentally open in laparoscopy, in open surgery, we can feel it and then say. If that could not be done, then probably 2 options. Either in few cases, probably 2 cases, I have added duodenal anastomosis, or in the couple of cases, I have added the hepaticojejunostomy for anastomosis. And accidentally opened bile duct, I'm not happy, because somehow the leak is more. The in a couple of cases, I had a leak. Very rarely it leaks, but whenever we open the bile duct into that anastomosis, sometimes it leaks. So first choice, electively deciding means I'll go and then do anastomosis separately, because by that time bile duct is nicely dilated in the supraduodenal portion. Either a duodenal or a jejunal anastomosis adds about half an hour or 45 minutes more to the procedure. That's it. No additional dissection is required.
Probably same rule loop you use.
Yeah, same rule loop. Because why I say same rule loop is the pancreatic juice is dried. So generally we don't combine the pancreatic and the bile in a normal situation, but in this case it is acceptable because the juice is less. Sorry. Dr. Baiju, what do you do in such a biliary obstruction?
I do a separate anastomosis actually, but probably in some situations, if it is a minor leak, probably I'll be including that into the anastomosis. But if it is major,
thing in the sense while coring out, bile duct opens up, you suture it to the parenchyma.
No. I'll be doing a separate anastomosis only.
Okay. In one case, I have done the same ruling. The other one, what I found is duodenum is quite okay. So no need to take a separate ruling. Just by you already duodenum is mobilized, so we can do a choledochoduodenostomy.
Oh, is it in the cavity or outside the cavity?
Outside the cavity.
Okay.
It's a separate anastomosis.
Okay.
I also had the same similar one situation where I did a separate anastomosis, not the same ruling. In fact, that's better. I mean, some other I felt it would be better, but quite often the incidence of bile duct stricture coming up in chronic pancreatitis, as we read more in literature or in the theory, practically I think it's not that much of a problem. What you say, Baiju and Senthil?
Yeah.
I mean,
no, but yes, it's rare.
It's rare, very rare.
But when you see a bile duct stricture, first thing that should come to our mind is malignancy.
Yeah, that's whole thing. And in that scenario, probably Whipples will be a much better relief to the patient than doing all these exercises.
I burnt my finger in one case where I did bypass, but later turned out to be malignancy.
True.
But in spite of...
For every person who is doing laparoscopy, probably might come across that.
That scenario is true.
Yeah. In spite of twice doing brush cytology, stenting, US, guided biopsy, everything negative, no mass could be found, but later had a malignancy. So even if it is not proved, as rightly said, doing a chronic Whipples in chronic pancreatitis with bile duct stricture is quite okay. Leaks are
much better. I think I had a similar kind of situation where I decided that I should better do a Whipples than doing all these exercises, and that was later on I felt that was a better decision than doing a head phrase.
And pancreatic anastomosis post Whipple is for CCP is very easy.
Yeah. Absolutely.
Anastomosis.
Absolutely.
There are three more questions from the audience. Actually, Ravisamy is asking, is USG always necessary to locate the duct?
We told it's definitely not necessary. If you find it difficult in spite of multiple attempts in puncturing the duct, still you could not find out, then probably you use it. It's not that you keep the ultrasound and then put the needle in. No. In difficult situations, we can use it. Otherwise, we have to open. Those who don't have the laparoscopic ultrasound, probably after multiple attempts, if still you could not do it, then probably make a small incision and then do it. It's not an essential thing. Maybe an urgent, maybe in few cases.
So Dr. Durerajan Somashekhar is asking the role of hand-assisted laparoscopy surgery in CCP.
Hand-assisted laparoscopy may not be of, for learning, it's okay. But for real benefit, even the incision which we put, it's an upper midline above the umbilicus. The same incision will be required for you can mobilize and then put for anastomosis. That sometimes we have done, though the benefit is slightly less. Maybe you could have added few or 2 or 3 more centimeter for a complete open surgery rather than the assisted one. The difference between assisted and complete open, the length is not much different.
I think just to answer on that, initially I was doing almost like assisted. What I was doing, I was enlarging the uptake port incision, delivering and doing the enteroenterostomy first externally. And after doing enteroenterostomy, I was pushing the loop inside, then was doing an intracorporeal LPJ. Right. So that was the initial days, I think.
For learning, it's okay.
Yeah.
Right.
So,
and another question from Surendra Shah is that how will you manage a case of chronic obstructive pancreatitis with a pseudocyst, which does not resolve?
I generally do open.
I do.
What about Dr.
Actually, this is the multiple scenarios.
No, but having said, before you answer, having said that, I have encountered very less. So pseudocyst complicating chronic pancreatitis very rare. As you said,
Even though theoretically it says that it happens, but we rarely actually encounter them, right?
I have not done combining pseudocyst with
LPC, I mean phrase.
Any other questions from the floor? I was asking Dr. Shubhalal sir to open the mic, but he is not seen now. Dr. Peethambaran, do you have anything to say? So actually, I think it's the time.
Hi, sir.
Yeah, Peethambaran, tell.
Yeah, nothing wonderful hearing the good talk from the doyen of laparoscopic surgery. And I'm happy that Sanadevan Education Foundation is doing at great heights.
Yeah, thank you, Peethambaran. Peethambaran is actually working in Palakkad, close to Coimbatore.
Yeah, good friend of mine.
Yeah.
Thank you, Peethambaran.
Thank you, sir.
Anybody else? Actually the advantage of Senadhipan Education Foundation is that anybody who is ready to ask questions can raise their hand and open their mouth. Unlike other association webinars, because unlike the other association webinars, usually the guests, the speakers will be in the webinar room, and the other people will be watching in stream. So that is not there here. You can very well ask questions to speakers. It's very liberal, and the time is, there is no time limit also.
It's better, Baiju. Next time, if you give some Zomato and Swiggy to deliver the dinner, then I think we can go on till midnight also. It's no problem at all.
Dr. Parveen Bhatti and Dr. Our Tata Memorial, yeah, they were sitting till 10:45. So, Shailesh Srikande.
Okay. That's a good. I mean, there is no time limit. That takes a lot of.
That's good. That's better.
Yeah.
Sunday night, anyhow.
Yeah, Sunday night. Yes.
Actually, I selected this time just because of 2-3 reasons. One is Sunday, everybody will be relaxed, and there will not be anything to do in the evening.
Yes.
That is one thing. Second thing is that Middle East people ask me, because most of the time we will be conducting the webinars on Sundays. It is working day there in Middle East. Sunday is a work day.
Their Friday is a holiday.
Yeah. They say they wanted to attend. They wanted to have it in the evening after 5 o'clock there. So it will be almost 7 o'clock here. So I thought of keeping it 8 o'clock. Now we have got another advantage that we have speakers from next month. We have speakers from Colombia and Ohio. So it's morning there and evening here. We can accommodate very well these people, and also the European people. Europe, it is 3.5 hours less, or 3.5 hours to 4 hours less. So we can include these people also. So it's an ideal time for all the speakers or the participants across the globe.
And most depressive evening or night is Sunday, because we have 5-6 working days. Even Monday is better because one working day is gone. right from the school days, I always feel Sunday night is the most depressive night.
Absolutely.
I think you have got right.
Next day morning, you are back on the track again.
Sunday night, we have, if we have 5 days of our working days, we have 5 more days. Monday night, we have 4 days only, 4 more days only. So Sunday morning is good, but Sunday night or Sunday evening is, we have a lot of working days ahead. So probably this is the right time to catch and then engage us.
Yeah. Actually, I was lucky that I chose the prime time.
Yeah.
You're always.
You are always lucky. Exactly. At the same time, we told. He is always lucky.
Yeah.
Anybody else? Now, Senthil and Manash, you can wind up.
Yeah,
You are-
thank you very much for the opportunity, Baiju, and thank you, Senthil, for spending the time well and effectively and so nicely in the Sunday evening. So thank you, everybody.
Thank you, Dr. Manas, and thank you, Dr. Baiju. Really enjoyed interacting with you people, and then I thoroughly enjoyed last 2 hours. I think one of the nice interactions we had in a long time. Thank you so much.
Thank you, Senthil, for accepting my invitation. Senthil, Manash also for accepting my invitation. It's a wonderful
Sure. It's a pleasure. It's a pleasure.
Yeah. Next week we will be having a global speaker, Dr. Leroy. He is speaking on transanal TME. Actually, we are expecting more than 500 audience. So we are increasing the Zoom limit also, because there will be participants across the globe. So we can meet 7:30 evening.
It's a good thing that Baiju you have doing it Sunday, because I have also started a weekly program on Tuesday, because so that it should not clash, and you always send me the flyer. So
I request other associations also. I requested the hernia people, I requested the AWR people to allow me to conduct this on Sundays.
Good.
They can take other days.
Absolutely, it's nice. Because now it is very much required for many people. Many people are actually, they want that this kind of engagement has to be there. So it's good. It's both way. It is.
Thank you all the participants who are joined from all over the country and across the globe. There are a lot of logins from Kenya, South Africa. I'll read out it later because that will be coming in Zoom analysis tomorrow or next day. So we will meet 7:30 p.m. Sunday. Till then, bye. We are signing off. Thank you.